From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
Welcome to this edition of Inside the 1581. I'm excited for my second opportunity here to geek out on artificial intelligence. And those of you who are our listeners, a couple episodes ago, we had a conversation with Brenton Hill with Chai about artificial intelligence and what it means not only to the healthcare community and to patients, but also what does it mean to the larger community, each of us as consumers. And so I am just delighted to have joining me today Byron Yount, who is a PhD. He's an expert in this. He's the Chief Data and AI Officer at Mercy. And here in Oklahoma, we have a number of Mercy facilities. And so Byron flew in from St. Louis to spend the afternoon with us. And Byron, thank you for coming in and joining us.
Appreciate the invitation. Thank you. Yeah.
So today, inside the 1581, we're going to talk about, AI 2.0. So we had 1.0 when Brenton was here, and now we're going to talk a little bit more about perhaps some real use cases in healthcare. And we had a great conversation just before we got started here today on that. And so before we get started, why don't you tell us a little bit about what you do as the Chief Data and AI Officer for Mercy?
Sure. So at a large, simplified level, I'm responsible for all the systems that collect data across the enterprise, curate that information, and do interesting things to it, right? Analyze it, create insights with it, build machine learning algorithms, some different types of insights, and push that back into the workflow to be consumed by our caregivers, either those taking care of their patients or those that are running operations across the healthcare system.
So, doing this, is this what you, obviously AI is new, right? So It's not like you went to school for AI, but certainly in your PhD, you've probably dealt with numbers your entire career.
Yeah.
So tell us about how your career progressed to what you're doing today.
Yeah, and it's not a maturity arc that every data officer, a chief data officer, AI officer is going to have, of course. What I've learned is that we've all had different routes. And I could go all the way back to my childhood and why I think that's relevant. But I'll start maybe with my doctoral education. I studied epidemiology, chronic disease epidemiology at St. Louis University, and was really interested in health and human thriving. So I took a position under Ross Brownson, was my mentor there. Wonderful man, and he ran the prevention research center there, and was a prominent figure in that space and in public health. And I got interested, of course, in chronic disease and what influenced that. And so that's really where my career in public health and not necessarily healthcare, but especially public health began. And during that time, I got a fellowship with the NIH. I did some studies at Washington University through that fellowship to learn medical statistics. I got introduced into large administrative data sets and programs like the Framingham Heart Study and the Offspring cohort that emerged from that, and developed mathematical techniques and used statistical techniques and back then, machine learning, right? Data science. There wasn't a lot of that going on in healthcare. This was back in 2007. To get insights from that data and to understand, what an individual's risk for future, disease was, cardiovascular disease, diabetes, these types of things. So really trying to project out the health span and ultimately the lifespan of individuals and populations. During that time frame, I also picked up program evaluation, got really interested in that. That helped me to earn some extra income, during the lean doctoral years, and just satisfied some interest that I had in systems and the role of system science in improving programs. And so I got introduced to Mercy during this time. And Mercy had received funding from the Missouri Foundation for Health, and I believe maybe one other health foundation. And I was hired on as a program evaluator. And I think you'll know where this is going. Mercy was one of the many systems to receive some of these awards, and the main clinic driving it was in Joplin, Missouri. And as fate would have it, the Joplin tornado broke out, destroyed the clinic, the hospital there, and tried to take the pulse of the the community away, really, and the organization. And I just became really impressed with the way Mercy responded. The CEO at the time, Lynn Bridden, was a prominent figure during that time frame. But all leadership was, community rallied, coworkers, the way that they were taken care of. I just knew at that point in time that if I left academia, which I was working at Washington University at the time, that I would join an institution like Mercy. And a couple of years later, they reached out and said, hey, we've got a need for a statistician and a manager. And oh, by the way, we've got a Center for Innovative Care, and we're really interested in opening up a virtual care center for a virtual hospital without beds. Of course, you know that Mercy became a leader in this space. And so I took it. I joined Mercy, and I started off as that manager statistician. I joined the virtual care center and helped them develop the programming and evaluate it there, and develop data and analytics, and introduced machine learning into the organization some 10 years back. And soon after that, a couple of years later, I was tapped by the then chief analytics officer and senior vice president for finance to develop a decision intelligence practice across the ministry. And at the time, we didn't really have necessarily all the technologies to do it. And so we started kind of saying what we would need. And that gave some of the early planning and strategy for some of our digital transformation that would occur later, and I'd be a part of. But then the pandemic kind of broke out.
Right. But you know what's interesting, Byron, is that, and I think most folks probably don't realize how evidence-based healthcare is driven by, and how important that data. So whether it's a public health, we think of public health. There's the folks that are working in our local county health department, but folks that are engaged in public health are looking at data. They're making decisions that is driven and is validated by the data. And our strategy or our approaches to addressing a health concern is driven and it is supported by the data.
Yeah.
And so to me, listening to what you're saying is that it's a clear indication that is where Mercy is. Mercy is very focused on making sure things are evidence-based, looking at the systems of care. How can we improve those systems of care? How can we ensure we have high reliability? How can we make sure that we reduce risk to our patients? And how do we ensure that we have the highest quality and the highest safety in mind when we provide care to our patients? And that's part of what you do.
Yeah.
But it's also part of kind of the whole AI conversation.
Yeah.
When you think about it.
Exactly. And, a big part of my role is all elements that affect that. It's the data and AI strategy. It's the data governance program. I was tapped to kind of start that at Mercy as well during our digital transformation work. Responsible AI, which is a big, sort of
well, let's get into that. So let's get into a couple of those concepts. So I think the last time we were here on AI 1.0, now we're here at 2.0. So we think of things generative, we think of the machine learning. Why don't you walk us through a couple of the ways in which for our listeners, how we might, the buckets we might put artificial intelligence in. And I wish there was a different name than artificial intelligence, right? Yeah. But I guess that we all get it now. But how would we define those as we get in deeper into our conversation?
Yeah, so two big, broad bucket areas. One, narrow AI, or some people will call it traditional AI. These are things like diagnostic algorithms that are running, algorithms that help identify rising risk. This individual or these sets of individuals are at increased risk for a disease or disease-related event. Right.
So we could look at what might be my blood chemistry as an example, and maybe match that up against other health conditions I have, and then say, okay, Rich, here's what we think you're at risk for. Here's the things we need to focus in on. Would that be correct?
Right.
Okay.
So the idea of using these types of AI is really all AI is to be more personalized, more predictive, right? More preventative at the end of the day, proactive with care. And that's one of the promise, probably the promise of AI and emerging technologies is that we can move further upstream and increase the health span of an individual, right? And reduce disease burden, not only of the individual, but also of society at large.
Okay.
And then, the other major bucket is, the generative AI and the stuff that's happening in that space right now.
So
right?
explain what the generative AI. I think that's where the folks think it's the most exciting. So let's talk a little bit about that. Yeah,
it is exciting, right? And it's gotten a lot of sort of buzz in the past year and a half, or perhaps a little bit longer than that.
It's more than just Chat GPT, which people think about when they think of AI.
Yeah. And it's such an interesting space, and it's going to continue to grow. It's going to continue to get embedded, and really, I think in the future will fall into the backdrop as just another capability that we use. It's just getting a lot of attention today because we don't understand it so much. I think you used the term expert earlier, and sometimes I don't know that I would say that anyone's an expert.
Right.
in generative AI,
unless they have an AI meme behind them. Right?
You're right.
Yeah, that's the expert.
Yeah, certain aspects of it for sure, but we're talking a very broad and deep space right now, and so much is being created. It's really even hard to keep up, right, with all the promise and all the risk. So those would what I'd call the two broad categories: narrative or narrow AI and general, or generative.
So what do you see as some of the emerging trends that we're seeing? And before we get into deeper specifics, I mean, what do you see? Is it the big trend in population health or in precision health for patients, or is it AI really burgeoning in all of these different pathways?
Yeah, I think it's pretty pervasive in many ways. The diagnostic AI and the algorithms that help make predictions about a future event, right, for a person or a set of individuals in a population, those are just getting better and better over time, right? So we're going to continue to see progression there. We're going to continue to see more integration, more interoperability, so that they can be used across all types of healthcare settings and systems, and just more value to the edges, where maybe the rural healthcare systems don't maybe have so much access to these days. We'll have more opportunity for access down the road, especially in healthcare systems that have invested in multiple technologies, including virtual care technologies. So that's a space. You hear a lot about AI agents these days. And in the future, there'll be multiple agents, that can work together and consist and augment care and care providers.
And when you say agents, explain that for our listeners, who those agents are.
Well, it's just an AI, right? So it's almost, I consider an agent, you might have heard co-pilot, is another term that gets branded by an organization, but it's essentially an assistive AI technology, right? And I think of it that way in terms of an augmentation of what you're already doing.
So it's a chat bot that most people are familiar with when they go in and they do an online purchase. This is literally a diagnostic assistant that is working with a caregiver, for example, that's sitting as their co-pilot, helping them navigate how they're going to program or how they're going to design the care that's delivered to their patient.
Exactly. And it can even serve as a bit of an overwatch, right? And,
perfect.
A second set of eyes, right? To be able to, sort of red team, an individual or another system altogether that's operating, another AI system. And so that's a fascinating time. More of the edge devices are getting more powerful each day, and more pervasive. And if they live up to promise, probably more accessible to more individuals. I personally have experimented with continuous glucose monitors over this past year.
Right.
Amazing bit of technology in that you can wear it rather discreetly. It'll cache data or store data on it and transact it or transmit it to your phone, where you'll have an app, right, that can monitor that over time, and you can relate that to behaviors, things that you're eating and what's the response look like. Did I sleep well last night? Now, how's my regulation of glucose during the day?
And you would call those edge technology?
Yeah, kind of edge technologies, right?
So I can call my Apple Watch now my edge technology.
Yeah.
Okay. it's living on the edge with the Ultra, I guess. That Apple could probably coin that.
Right. And these may use cloud-based compute, but more and more, some of them are also able to do some of the compute and assessment on the device itself. And that's technically what we mean by edge. But a lot of Internet of Things devices that also can be connected with one another. That's the other thing. We're talking about AI systems. A driving car uses narrow AI, but it's an AI system that uses lots of technologies to accomplish that feat. You just don't want it to read your radiographic image. Right. So, in that area, you're getting into more of the general intelligence space. But there's just a lot of promise, I think, that'll come from that area. Personalized medicine, has more promise when it's paired with technologies that can, segment individuals in risk and, appropriately, phenotype you. Right, you look like this, and this is likely your trajectory. And what we've understand about you and others like you is that this set of medicines, for example, may be especially helpful, right, and can help prevent and lower the risk profile of even having to take medicines altogether, right? So I just think there's a coalescence or a merger of all these technologies together that present a whole new reality that we haven't even fully imagined yet.
And it really does help to get down to precision healthcare. I mean, it's really designing a treatment modality that is very specific for me based on the information I've collected and based on the information I've sourced.
Right.
So it seemed to me that, really, and we'll talk about this after our break, what this future means for us, the potential certainly to, when we engage in this precision medication, reducing cost, creating higher reliability, evidence-based, again, which what we want to make sure that we have.
Yeah.
Before, because we are going to take a break in a second here, but I did want for our listeners to understand, and I think this is something that you and your team focus in a lot, and that is how important security and data security is.
Yeah.
Because oftentimes I think that's what folks find themselves concerned about. Who will have this information if you're working and using this technology to improve my healthcare? Before we go to break, tell us a little bit about why that's important and how you guys, how you approach this to make sure that you're doing everything you can to protect that health information.
Yeah. So I think rightfully so, most people feel like the information that's collected on them as a healthcare consumer is their information. That's exactly how healthcare organizations feel, like Mercy. We're not exclusive in that, right? And we do all the typical things that you would need to do: SOC 2 compliance, safeguard the data, making sure that you're meeting safe harbor standards of removing identifiers whenever information is being transacted across systems and looked at, making sure that only the right people have access to that data, and set up any kind of signal when there's an inappropriate access, right, and then follow-up. We've got robust security teams and standards, compliance teams, ethics teams, mission teams. But it's not just about the individual things you do. It's in summation across the system. You're really caretaking an ecosystem. I often use a mental model for my role as a master gardener, and I'm a steward of this garden. And so we are trying to not only create efficiencies across that ecosystem, but increase the security posture and reduce the risk that exist within that environment, inclusive of using some of the technologies of the day and some of the technologies that people are scared of, right? Including AI, which can actually be used to help reduce risk and identify when there's inappropriate activity, sort of going on within a vast data space and network.
Well, and that's all important. And I think, that's why when we come back to the break here in a second, we're going to talk about certainly what are the next wave exciting technologies. We're going to talk a little bit about mimicking, and what that means, but certainly that next wave. And I think that's where folks are really very interested in what comes next. So when we come back to Inside the 1581, we're going to pick up our conversation with Byron Yount, who is the Chief Data and AI Officer at Mercy. But first, we're going to hear from our sponsors at Forefront Healthcare.
Are you looking to elevate your facility's support services? Forefront Healthcare is a leading provider of food, environmental services, and facility management solutions to hospitals nationwide. Recently recognized in 2023 as a top 100 best places to work by Modern Healthcare magazine, our comprehensive boutique approach ensures measurable clinical outcomes tailored to your facility. Elevate your facility's patient, staff, and family experience today by visiting forefronthealthcare.com or call 800-684-6450.
Welcome back to Inside the 1581. As I mentioned, we're here today talking again about what I'm calling AI 2.0. And joining me is Byron Yount, who's the Chief Data and AI Officer at Mercy. And so, Byron, when we broke, we were kind of teasing out to our listeners, what we would talk about next in terms of the next big thing. Mm-hmm. So I know you've been privy because of the role that Mercy has and seeing the next big thing. So before we get to that, we know we are using AI to help us in our diagnosis. Let's use radiology, for example.
Sure.
We're looking at it in ways, certainly in the oncology space. We hear mostly about that. And so maybe you can give us a simple example of what is most commonly used today, and then what is out there that's potentially mind-blowing to us, because there's a lot of new uses for this that I know you've had the opportunity to take a look at.
Yeah, well, no, thank you. And I've got a question for you, I think, after we kind of go through this one. Just a curiosity. So, yes, radiology, even digitizing things like pathology, which we haven't done a lot in healthcare, has a ton of potential, right? So there's more information stored in things that we've digitized than in other forms, right? There's lots of information that are just hidden there, and associations that we just may not even understand just yet. Even in looking inside the eyes, right? Which are, they say is a gateway to the soul, but it's also a gateway to one's health. And what can you know?
You can see you've had a stroke, right?
Yeah.
Based on your eyes,
By studying that. And so I think those kind of things will be certainly more commonplace. And we're working with an organization right now, which is not uncommon for Mercy, and I think will become more common in community health care settings, that has an emerging technology. They're trying to get FDA cleared and approved, and it's on ECG waveforms. And it basically is they've licensed that technology and a set of algorithms that they want to test and prove out. And these will be deployed and available in primary care settings where there's just typical machines that your primary care may use to get a rhythm of your heart. But the primary care provider may not have a lot of experience in looking at those waveforms that come out and associating with them with anything important. So it's not necessarily an all moment, but just when you think about how many primary care settings there are, how many people go to see primary care, and how much underlying disease there is, burden, and syndromes. I think with congestive heart failure, the numbers in some subpopulations are quite staggering. Upward, I think, to 2 to 4% is what I've understood of undiagnosed, and eventually one day that'll manifest, clinically. It won't be so subclinical anymore, and of course we know that's associated with risk of stroke and other things. But just to be able to to use AI to help pick up on these things in primary care settings, right? And then have that verified with a specialist or an expert, sort of somewhere else, I think could be quite transformative in healthcare. Or these technologies that can literally look into your eyes and understand something interesting about your health that maybe you didn't know or we didn't know before, or would help put together of, oh, wow, I've been feeling this way for a number of years and I just assumed it was X. And it turns out that it's just, canary in the coal mine for something else that's going on. And that's really interesting. Being able to even go down to lower cellular levels, what AI would be able to do there. The mitochondria is the source of a lot of disease and dysregulation and disability. And so being able to work further upstream and being more proactive again and predictive is really interesting. These agents working together.
Sure.
Fascinating. I got to set in on a session with some researchers that were kind of showing me the next wave of some of the technologies that could be coming out. And they gave one of these agents a simple task, well, seemingly simple, but it's quite sophisticated. And it was to create an image, right? And that image was to be an image of a corgi running through an agility course, essentially jumping over a hurdle with a ball in its mouth. And then another agent was there instructed essentially to watch this.
And this would be an example of mimicking, correct?
Mimicking, yeah. And mimicking and then also, red teaming, overwatching, improvement, active improvement of one agent trying to help another. And so it was given that instruction. And so as, this AI is creating this image, which looks really compelling, the other AI essentially notices that, it's not, it could be better, right? Essentially that it didn't capture the effects of gravity well. And so a corgi is a little, got a round, hefty body with some fluffy, hair around it. And so the expectation would be as it's going up, you would see compression of the hair, and as it's coming down, you would see that hair go out because the body mass is going to be accelerating to the ground faster than the hair around it, and air resistance and everything else. And sure enough, the secondary AI, the AI agent, had rewritten the instruction and the script and improved the outputs of the first, right? And so we're going to see a lot more of that. We're going to see a lot more of AI systems working together, right? Multiple agents that are trying to help, a set of care providers also network together, trying to learn at the same time, not just on what that physician or care provider is doing, but what the mass of them are. And so it's an interesting space. It's just an interesting opportunity. What is going to be intriguing is what comes out the imagination of people as more of these technologies hit.
Well, and we were talking earlier, before we came on. If you start to look at what AI can mean, and you plugging it into these other large data sets, and the ability of these machines to mimic and learn from one another. So, as I postulated, can you have a scenario where you do a live body scan? You have, one AI who is, I gave it a name, right? AI that is taking that information and creating a simulation that a surgical team can come in on a very complicated procedure with the potential of a hologram generated. So you literally could practice operating on that body and having the AI throw any potential adverse event that could take place so that your care team is ready for any of that and still be able to accomplish the procedure and get better at it with their proficiency prior to actually having to make the first incision on the patient. When you look at how you can reduce risk, how you can improve outcomes, that in of itself, that is not that far away.
Yeah.
And I'm sure somebody probably is doing this as we speak of it, when you think about it.
Yeah, or just being able to simulate rare events.
Right.
Right. I mean, rare events happen, and we're not always prepared to manage those because we don't see them that often, right?
Right.
But certainly, and that way you can kind of game that, role play that, and people can be more adept to all of these things that can go wrong, right? And know how to respond to it.
And some of it is providing some decision-making assistance too. So,
That's
I mean,
true.
if you're a pilot and you're working in a simulator, a lot of different potential adverse events can be thrown at you, and you have to figure that out as a pilot.
Yeah.
A surgical team going through the exact same thing and recognizing that in a simulation, if you put something in front of them, how do they respond, or how can the assistive technology help them arrive at what should be the approach if they need it because of some particularly exotic event that takes place during that procedure. It's
Right.
going to make us all better clinicians.
Right. Yes. In certain, and not even just clinicians, but people in my position, right?
Sure.
Back office folks, right?
Which is the next question. So we've been talking a little bit about clinical applications.
Yeah.
But there are a lot of places where we can use this technology, whether it is in improving operational effectiveness or operational throughput. It might be not only that, the direct care, but the handing off of care.
Yeah.
It could be facilities management as well. So talk a little bit about what Mercy may be looking at in those other areas that are outside of the direct patient care.
Yeah. So in both operational back office, settings and clinical operational settings, there is handoff of information. I call it information transference. And there's generally a challenge today, and we've got a lot of information and to sort through. And not all that information is equal, right? But there's a lot to sort through and to figure out what matters and to hand that off to the next person. In a patient care setting, these handoffs happen all the time, right? One example that I'll kind of walk us through is that a patient walks into the ED, they're presented with some kind of illness or complication. We get a problem started. We start to look at their history. We begin to draw labs and maybe do some images, and then all of a sudden you're creating a lot of information about that patient. And that patient is going to go to a new setting after the ED, hopefully, right? And that's going to either be into an inpatient setting, or it's going to be home. It's going to be into home health care. It's next setting that they may walk into is with their primary care provider. And so these handoffs are happening where a nurse needs to inform, for example, a nurse in the ED, then the nurse in the inpatient setting, hey, this is what's going on with this patient, right? You're going to be taking care of them next. And so here's everything that we know about this patient thus far. And, those handoffs are happening every day, some in better ways and others in more standard formats than others. But we can use technologies like AI to create these really reliable, best practice standard handoff documents from one environment or one nurse to the next, and securely to that next care team where it doesn't go anywhere else, to their device or within the medical record. And it saves a lot of time, essentially, for those nurses that may be spending an hour of their 12-hour shift trying to summarize this information to hand off, and now that's down to dramatically lower than that. And then that frees up their attention to do other things. And so, that may be increased communication with patients. It may be other caregivers, just general satisfaction. They get to go and do other things of interest, restoring their attention so they can become more intuitive.
Or scoring the patients in your safety huddle.
There you go.
You do those safety huddles at every shift change, and you can come down and quickly see, here are the patients that we really need to make sure that we're focusing in on based on what we've learned might be some of the potential responses in their recovery that we need to be aware of.
That's right. And one of the things that's been interesting about engaging with this work is that it has ancillary benefits. And what we've noticed is that there is a bit of skepticism, of course, about using this technology. But you can leverage that for good, and that people will be paying more attention to it. And it can become a great mirror of what's going on. If it's something doesn't quite look right, you ask the question, is the technology? In this case, what we found is that that's generally not the case. We built it such that it's not really producing errors. But what is often being reflected is if there is something that doesn't quite look right, it's maybe something about a process that that can be changed, that can be improved. Then you're getting into process improvement and process redesign a learning healthcare system. And now you've got that happening in this space. And then if you propagate that across an enterprise where all of these handoffs and transfers are happening, and in these transitions of care, you're alleviating a lot of burden, but you're also being able to watch the system work and learn where to improve upon it.
And you can create targeting too. So let's talk about imaging for example. A radiologist who's seeing dozens of screens a day, we're humans. We do get tired, right?
Yeah.
And to be able to have the assistance of technology to be able to identify, here are some things that we've seen. Now you, the radiologist, here's something you may want to spend some additional time. We had Fuji here with some of their updated, brand new technology on breast imaging. And in Oklahoma, we struggle. We have some of the highest mortality in breast cancer, and we have some of the worst screening rates in the nation. And so, as an association, we're trying to look for ways to further make this technology available and to ensure that more and more women do have access. But when they were showing us, walking us through their new imaging, how this technology is able to detect things that it might take a radiologist a little bit extra time. They'll catch it, but to be able to prioritize and to be able to see it and then quickly drill into it, and using the other illumination technologies that come along with it, how that can be transformational in the diagnosis and an earlier diagnosis for some women.
That's right. And many of these companies that are working on advancing this technology, some of them, especially in the radiographic space, started a decade ago or so. And they're
probably more advanced when you think about it, because they clearly saw the opportunity here.
That they are, and they leaned into one of the more clear and compelling opportunity spaces. But now they're also contributing to knowledge. I mean, many of these companies, I think, have produced like 100 papers, right, into the scientific literature about what we understand and know about radiology and using these kind of technologies. And so it's a fascinating thing, and this is a common comment these days, but it's getting so good, you have to ask why you're not using it if you're not using it, right? And why you wouldn't use it if you were a care provider. And eventually one day it may be simply required. It becomes a form of malpractice if we're not leveraging it. And again, it's not really there to replace individuals right now. I mean, we've got shortages in healthcare. That's generally not a problem. Sure. But improving us, right, overall, and de-risking the environment, making things safer for patients, and identifying things earlier to be more proactive, and hopefully avoiding, perhaps downstream surgeries and events that may or may not, be needed eventually. That's a promise of a lot of this. But all of this is transformation. It's systems change, and we have to be really thoughtful.
And so if we look at what Mercy is doing as a health system, you have rural hospitals, you have urban hospitals, you have I believe you have critical access hospitals as well. So you really run the full gamut of hospital delivery. What is the vision for Mercy in this space of ensuring that not only do we appropriately apply artificial intelligence, but making sure that we have it available to all of the patients within your service area?
Yeah, I think you've hit on it, right? And that is, we don't want differentiation. So if you go into a critical access hospital or a rural hospital, you should have similar experiences and technologies available to you and knowledge that you would at some of the major facilities that may be more resource heavy and intensive. So we're trying to use the technologies of the day to kind of level the playing field a bit. And we've done obviously a lot of work to invest in this and invested in our cloud and our digital transformation to help make this happen. But if I take a second, we've got phenomenal operational leadership, right? Just that nurse handoff.
And it takes
example.
leadership to drive this, particularly if it's not something that's necessarily compensable when you deliver the care.
Yeah, it's got to be part of the ethos, the
Right.
culture. People buy into it. Mercy's got a long legacy and history of being inventive. Catherine McCauley, the founders of the organization, went out to where the need was, and that's essentially what we were doing when we ventured on to pioneer in virtual care. Same thing about trying to lead within AI is let's just get out to the edges and resolve maybe some of the inequities that might be there, and really push what we think our care model can do, and set ourselves as much as we can as an exemplar for other community health systems. We think we're credible, we think we're capable, and we think we're relatable. We look like 90% of healthcare in this country. And a lot of academic medical centers that get into this space can't make that claim, right? They're just different by design. But it's important that community healthcare systems like Mercy pick up the challenge and they pick up the task and they try to do this, because that's what's going to help us, resolve in rural communities and critical access across, all of healthcare.
Is there any place where patients can play a role in helping to evangelize this technology and ensuring that we are getting, the most reliable information, or that we're making sure that our friends and neighbors understand that it's available? Do you see a role there for patients in this?
Sure. Everybody's got a role. AI.
I'll give you an example.
Sport,
on my, as we called it here, my Edge device, my Apple Ultra here, I have a number of apps on it, right?
Yeah.
So one of the ones just a number of years ago that I signed up for was a cardiogram. It was an app, and they were using individuals who had downloaded the app to offer to share their data. So I was like, if I can learn something from it, if others can learn from my data that's being shared back to the researchers in real time, I filled out my HIPAA forms and everything else, submitted that. I look at what the opportunity for that crowdsourcing of all of this that's out there, what we can do to further accelerate this, A, B, ensure that this nation becomes the innovators of all of this. And so that by being the innovators, we also own it, and we have the opportunity to have influence over how it improves health across the world. So for me, that's kind of why I asked the question, because I think we have a role. The question is, how do we share that with the rest of the patient community and even beyond the patient community to the families of patients?
Yeah, I think the more that we can educate one another within the healthcare system, and that gets transferred on to patients, right? Then they can take that and propagate that as well. There's a certain amount of self-reliance, right, and personal responsibility in all of this, and you're taking up the charge, obviously, to leverage technology that's available to you, and I've done the same. I'm really interested in it. I'm trying to contribute to the understanding, the progression of this, and not just for progression's sake, just because there's a lot of promise here, but in order to realize it and to avoid any concerns and risks that you think might be present, you want to lean in. If you've got something good to say and you feel like you've got an appropriate cause, get involved. I mean, even organizations like CHAI, the Coalition for Health AI, have patient advocacies, right? And so I think people could do more than what they recognize, but understand that you're consuming it already. I mean, these technologies are already in the devices that you use.
Right.
And so get educated about that, right? Push the envelope, request more transparency, and really put pressure. My read thus far is that this is going to be a difficult thing to regulate, and it's going to be taking communities, right? And so regulate at the level that might make all people comfortable anyway. So public, private partnerships are really an important thing here. And it's going to take sort of all comers, all kinds, and that includes the patients themselves.
And you're right, because that is a challenge, I think. How do you regulate it, and how do you have appropriate regulation? So what you don't want to do is have a model in which we stifle innovation.
That's right.
And then we can't grow. We can't really experience this technology in its fullness. You kind of look at the internet. Imagine if we converted the internet to a public utility back in the 80s, or even many, many years before, when it was part of our research institutions. But the commercial applications would be nowhere today. The economic commerce that's come through the internet, our ability to communicate as businesses, as individuals. So we have to figure out, how do we best regulate this, ensure that we have safety, it's reliable, it delivers on what it's promised to deliver on, but we don't stifle the innovation.
Yeah.
And
that's key.
and that's what's exciting about all of this. Any other thing that you want to add, Byron, to our conversation today before we close it out?
Well, I think it's just to advocate that if there's organizations that really haven't gotten involved, a good way to do that is to start with some of these entities like CHAI, right, the Coalition on Health AI. If you don't know and don't necessarily have teams, you can still contribute. You can learn about the space and bring good information back to your organization. I think that's important. I think holding back may actually be creating more risk. So just step into it, right? And potentially there could be a large gap to try to recover, right? If institutions and individuals kind of wait too long to attempt to engage and try to make something good about the innovations that are happening in the space. I just believe in what I'm seeing right now is that people are really leaning in, and they're really attempting to use all of these emerging technologies to really de-risk environments. And of course, there's always going to be bad actors, but how are you going to remove all of that, right?
Right, and it does create a new standard of care for us.
That's true.
And we want to make sure that we do that. We also want to make sure that we're taking advantage of every tool to improve the patient experience, create higher reliability, reduce risk to the patient, reduce risks to the organizations. And I think using technology like this does create that opportunity. And it won't be very long before we have that little tricorder that we used to see on Star Trek doing some of this virtual analysis as we're seeing today, just on glucose monitoring. You look at that, what does the next future hold for us in the use of this technology and new point of care devices that are coming our way?
Yeah, I'm excited about the space. I remain cautious, but I'm certainly excited about it. Yeah.
Well, Byron, thank you for joining us today. It was just a delight to have a second conversation on this as we wrap up our episode of Inside the 1581.
Well, thank you for the invite. I've really appreciated it. And I actually had a question for you, and that was, what's behind the 1581? What is the story?
Great question. Inside the 1581. I think because of that, you're going to get one of our classic mugs here. I don't think it's on Etsy yet.
I've been eyeing it.
But we'll have to give you a mug on that one. No. When we were, part of what we're doing here today is just to create conversations about what is going on within our state. And our state has 1,581 miles of border. So
clever.
Inside the 1581 is how we came up with the name for our podcast. But our goal here is to identify areas where we can tell stories. We can share the great work that hospitals are doing, and Mercy is an example of that, or the partnerships that we have, or are there people within our state that have had a material influence or impact on our lives, on the care that we receive, and how we can position and reposition Oklahoma to a much better place. And our vision is that we will move from where we rank in our health performance as a state to a much better place. So Inside the 1581 allows us to tell that story. So thank you for that question.
I love the format. I love what you're doing. I think it's great, and appreciate the invite.
Well, we appreciate it too. So as we wrap up, I want to say thank you again, Byron, for joining us in this edition of Inside the 1581. But before we go, I want to extend a huge thank you to our sponsors at Forefront Healthcare. And our producer, Alex Taylor, who puts all of this together, and then we'll edit our YouTube video for it as well. And to Susie Wallace, who's the Director of Communications here at the Hospital Association, who puts all of this together and keeps the train running on time. So please make sure that you subscribe and follow us and stay up to date on our future episodes. I also want to mention the music that we're using in this track and in every one of our track is Gunslinger by Ends of the Earth. They provide the background music, and we appreciate that. And again, we hope you folks will subscribe and check in on us on our next episode, which will probably be coming in the next couple of weeks as we come together and celebrate everything we're doing inside the 1581.